here today to discuss with you the effects of dexmedetomidine on postoperative nausea and vomiting in intra-abdominal surgical patients. So the problem here is that post-op nausea and vomiting is a common surgical complication affecting up to 80% of patients who have risk factors and 30% of the general population having surgery. Those risk factors include things like female gender, non-smoking status, a longer surgery time depending on the opioids that are used, or volatile anesthetics. And then this occurrence happens despite efforts to reduce POMV that are currently being used already. And this issue is persistent. So some of those things that are being done are like non-opioid or opioid-sparing techniques, blocks, things like that. So POMV leads to increased healthcare costs and patient discomfort and prolonged hospital stays. The purpose of this study was to evaluate the POMV rates at the clinical site where the study took place, also to analyze data at the site and compare various data sets to determine the effects of dexmedetomidine administration within intra-abdominal adult surgical patients. And this was to see if dexmedetomidine administration did reduce the POMV incidence. Another aim was to provide targeted information about dexmedetomidine and how it could reduce POMV, which was what was found in literature, to the CRNAs at the facility, and the aim or the target was 80% of the working CRNAs at the site, and then to reevaluate the POMV rates there or data to determine the effects of the information provided to the CRNAs, and then to collect a post-information survey to determine the usefulness of the information received by the CRNAs. The literature review and synthesis included 4 randomized controlled trials in total, and the Johns Hopkins evidence-based model for nursing was used to classify the data and the level of evidence provided. So the articles were strong and supportive of the outcomes, but only 3 of those trials demonstrated a reduction in POMV. The last article provided valuable insights and information, but the results from it had to be compared to the general POMV rate found in other literature reviews because it did not have a control group. Though it was still valuable information in many ways, that was a weak supporting portion of the evidence. Study design, so quality improvement project that had IRB approval from Murray State University. I also received approval from an evidence-based project committee board through the hospital's organization. And both committees approved the project through May of 2025. It was a retrospective data collection project. The data collection occurred from January 2023 through July of 2024. There was a total of 935 patients, and the data was categorized into 4 different data sets. In June of 2024, this is when the dexmedetomidine information was disseminated to the CRNAs. This was done over 1 week in the 3rd week of June, and the information provided was benefits, side effects, ideal population, commonly found doses, and the POMV reduction found in literature review. After that, the CRNAs were asked to fill out a post-information survey with 4 questions, and then those survey results were analyzed, and then that data was then collected 1 month following that information dissemination. The setting description, so this was a hospital in Kentucky. It was a full-service hospital with approximately 200 beds. The cases were intra-abdominal cases requiring a recovery in the post-anesthesia care unit. And the data that was compared was if the patient received an antiemetic, then they had post-op nausea and vomiting, and this antiemetic was given in the recovery care, or during that recovery care in the PACU. There were 8 operating rooms, and there are also 8 recovery bays in the PACU, and this is all part of the surgical services area. And for the CRNA information dissemination, this took place in the surgical services area in no specific place, just at a convenient location throughout that week, just whenever the CRNA and I had time to perform that, and at whatever location was convenient at that time. So the sample size were patients over 18 years of age, having intra-abdominal surgery and requiring general anesthesia that placed them needing to recover in the PACU. The CRNAs that received the dexmedetomidine information were 80% of the CRNAs who primarily worked at the facility, so that meant that I needed 3 participants. I had 4 total, and I excluded travelers that rarely visit to the site. So if they just came there, you know, once a month or something, or even once every other week, then I excluded them from the information sessions. So for data collection, the PONV rate determination, so it was a retrospective data collection organized into monthly increments so that I could determine what the highest rate was on a monthly basis, the low, and also what the average was. And then I used a electronic health records management system to collect, sort, filter, and organize the unidentifiable data, and then report that to me. The antiemetic administration was the indicator, so if they received any antiemetic in the PACU, that's what made them qualified them as having PONV. And I did input all of the numbers into Microsoft Excel and use that to create charts, and also to perform paired t-tests to just compare the different categories of data, or the different data sets. So for the data collection, the PONV data analysis, so I applied those filters. So for all 4 data sets, I included patients over the age of 18 with a PACU recovery, and then looked at with and without an antiemetic, just so I could determine the rate of PONV. And then for the first category, I included all surgeries that fit those other categories, but then for the other 3 data sets, those were just intra-abdominal surgeries. And then for data set 3, these were patients who received dexmedetomidine, and then data set 4 were dexmedetomidine patients were removed from that data set, so it was, you know, without dexmedetomidine. So for the dexmedetomidine information survey, the project was explained to the CRNA, and then they were invited to participate if they wanted to. And if they did, which all of them did, then they completed an informed consent. The information was verbally given to them, and then they were given the opportunity to ask questions or discuss anything that they wanted to. And then they were given a QR code on paper that they could scan with their smartphone, and it took them to an anonymous electronic survey that they could fill out at their convenience, but they were asked to complete that by the end of the week, which was Sunday, as the survey would expire at that time. The survey included 4 questions All the CRNAs participated and got that completed by Sunday. So all of the POMV data was reported in percentages, and the percent of patients experiencing POMV was the comparison factor between all of the category, the 4 data sets that I had. And the PARE-T test was how I determined whether it was significant or insignificant changes within the data sets. So the survey was created using Google Forms, and Google Forms also calculated my results for me. The questions were yes/no format for 3 of them, and 1 was an open-ended question. The data collection for the post-dexmedetomidine information, POMV data, that was collected in the same fashion that it was prior to the information being given out to the CRNAs, so there was no changes with any of that, collected in the same way. And then for bias, I just tried to have some self-reflection. I used the open-ended question in the survey and then just neutral language throughout the survey and whenever I was giving out the information about dexmedetomidine. And then for the results, so for the first data set, the general POMV rate was about 18% for the monthly average, and then the lowest month was 12%, and the highest month was about 30%. For the second data set, this is the data set that are intra-abdominal surgeries. Monthly average of about 41%, low was 22, and high was 62. In the third data set, this is the patients that received dexmedetomidine having intra-abdominal surgeries. The monthly average was about 25%, low 44 and high 67. And then the last data set were those having intra-abdominal surgery without dexmedetomidine. Monthly average of 36%, low 12% and high 56%. So the information survey findings, so the 4 post-information surveys completed, all the responses were positive, there was no negative feedback, all questions were answered, and there was no suggestions for improving the information session. And then for the post-dexmedetomidine information POMV data, there were no significant changes in the number of administrations through the though the number of administrations was less in July compared to June, it was not a significant change. So the interpretation of the findings for the POMV data, so the general rate at this facility was lower than the general rates found in the literature research material reviewed, which was 30%. So I think the high was 30% there at that facility, but the average remained below 30%. The incidence of POMV was expected to increase as the surgical population changed to intra-abdominal, and that did occur. The rate was as high as 80% in the literature review in this population, but the facility remained well below that, with the highest percentage being 62% and the average being 41%. So I thought that was quite low compared to the literature review data. The incidence of POMV was expected to be lower in the patients who received dexmedetomidine, so I was very surprised to find that the patients receiving that had a higher incidence of POMV. So that was very surprising for me. I was very surprised to find that the patients who did not receive dexmedetomidine had the lower rate of POMV incidence. So that was kind of a shocker for me. I thought it would be the other way around. And then the dexmedetomidine information survey. So it was a valuable tool and provided some good insights. The participants said they found the information valuable, and they expressed intention to use the medication more to reduce POMV in their practice. And then the POMV dexmedetomidine information data I would expect an increase in the number of dexmedetomidine administration based on the survey results, but that was not what occurred. There was not an increase in the number of administrations. Though it was insignificant, there was actually less administrations in July compared to June, again, though it was an insignificant change. And then implications of findings. So the data suggests that patients who did not receive dexmedetomidine had a lower incidence of POMV. So this project demonstrated that dexmedetomidine did not lower the incidence of POMV, which is the opposite of what was found in the literature review. And then the dexmedetomidine information survey, it was a cost-effective intervention and could easily be implemented. All participants completed the survey, and the results indicated that the dexmedetomidine would likely be used more often, and providing information through this method was effective. However, the post-dexmedetomidine information administration numbers did not increase. So this study did not indicate the information did not indicate that the information session was effective for increasing the administration of dexmedetomidine as a medication to reduce POMV. So even though the CRNA said that they were going to use it more often and said it was a valuable tool and that they thought it was effective, the data did not reflect that. So limitations, so there were several limitations to the study. So in both categories of POMV data and post-dexmedetomidine information data, all that data was collected in the same manner. So the history of the intra-abdominal robotic procedures is unknown there, so I don't know when those started. Did they increase in number, at what point? I don't know any of those characteristics of that procedure history. Other medications that can cause POMV were not evaluated. And of course, medications, many of the ones that we use often can cause that. Different CRNAs come and have worked in that facility, and they provide various anesthetics using different techniques. And then dexmedetomidine information survey, there was a limited sample size, and it was difficult for me to get 80% of the full-time staff, I felt like. So I think that sample size maybe should have been a little bit bigger, and I'm not really sure how to get that, but maybe, provide information over a larger time period. That might be more useful or helpful. And then also providing a pre-information survey to assess the knowledge of the CRNA before giving the information out would have been helpful so that you could compare it to the post-information survey. And then also for the post-dexmedetomidine information POMV data, the CRNA's dexmedetomidine knowledge could also affect that. And then just something to mention here at this facility, they began using a reversal agent in the middle of June, known as neosigmine, that can cause POMV. That's a known side effect. And so the pharmacy asked that they change and start using that medication rather than another one that they were using previously that did not cause POMV. Recommendations, POMV data. So future studies should be completed to include other factors such as gender, medical history, of motion sickness or POMV, non-smoking status, volatile anesthetics, and duration of surgery, because all of those things can increase the risk of POMV, and so those should be looked at as well. And then for the information survey, future surveys should include a pre-survey to evaluate existing knowledge, so that way it can be compared to the post-survey. And then a larger outreach to the CRNAs, so that way more CRNAs can be included, so the sample size can be larger for the post-dexmedetomidine information data. And then last is just the references. There we are. Thank you.